Good afternoon, and welcome back to Good Samaritan Facebook Live. My name is Dr. Scott Stein. I'm a family physician here in Vincennes, Indiana, and Chief Medical Officer of our Good Samaritan Physician Network. Thankfully, we'll be taking a break from our usual COVID stuff that we hit nearly every week and talking about a new topic this week, which is very specific to the month that we have just entered, which is Lung Cancer Awareness Month. Important to realize as we go out through the entire year, there's always months for everything, but part of that is to draw attention to things that maybe people won't think about, which is prevention and early diagnosis. And lung cancer prevention has changed a lot over the course of the past 10 years or so. So we're going to talk a little bit today with a couple individuals who are intimately involved with this program. Patty Innert, who's one of our directors of this program, and then Dr. Jennifer Young, one of our radiologists, specifically an interventional radiologist. We'll talk a little bit about that later. But Patty, can you tell us a little bit about what the program is and how that functions here?
Yes, I would be happy to do that. So lung screening is for people who are heavy smokers or have been heavy smokers and have quit in the past 15 years. So those people who fit into the age group, and we go by CMS guidelines, so that's 55 to 77, that meet that criteria with the heavy smoking, can be screened here at Good Samaritan through low-dose CT. So it is a CAT scan, but it's performed at low-dose parameters, about a fifth of the normal radiation dose, which Dr. Young can comment on. But so people should feel comfortable having it done. It is a screening exam. The patients are expected to be asymptomatic. And I get asked a lot, what does that mean?
Sure.
So for that is someone who is not having any lung symptoms. That means, no coughing up blood. You haven't suddenly lost a lot of weight for no reason. You're not actively taking antibiotics because you have a lung infection. And then screening is yearly.
Yeah, so and the reason that this is so important is if we kind of stratify and look at all the different types of cancers that we deal with, some cancers are preventable. Some cancers can preferably be detected as an earliest stage, and then unfortunately some cancers we can't do anything about. Lung cancer is in the top 3 for us. In fact, it's the second most common cancer as far as men and women are concerned, behind breast for women and prostate for men, but unfortunately it's the most lethal of the cancers that we see. And so tell us a little bit about, as far as the process of the screening, what you guys look for in radiology.
All right, so as you know, I'm a radiologist, so that means I am skilled at looking at CAT scans and trying to figure out what is cancer, what is not cancer. We have very specific guidelines that we follow that's supported by data because we have done millions of CAT scans throughout the United States. So we are getting very good at understanding what nodules look like cancer and what nodules do not. Sometimes it's the size that we're looking at, sometimes it's the shape, sometimes it's the density, but there are lots of different things we're looking at. And every time we do a CAT scan, it's pretty common to find nodules. But not all of those nodules are cancer. In fact, most of those nodules are not cancer. And so we will go through all of our parameters and find out which ones are suspicious, and we put people into a category. And so some of them we say, this is definitely not cancer. Come back next year, we'll check again. Some of them are, this may be cancer, so we'll do another image, in 6 months and see how it's looking. And then there's some that are more suspicious and more likely to be cancer. And so those people need to go for extra testing. And the purpose is to test early and find out if this is cancer before it spreads to anywhere else. As you were saying earlier, this is a very deadly kind of cancer compared to other cancers. However, people with stage 1 cancer, which means it hasn't spread anywhere, do much, much better if we detect it early than people that are having stage 4 cancer, which has spread all over the place. Those people do not live very long, unfortunately.
So interestingly, this is something that's relatively new. If we look at all the cancers that we deal with, there aren't very many that are preventable. One of the most great successes that we've seen throughout all of medicine has been pap smears preventing cervical cancer. Colonoscopy in the last 10 years has seen a significant improvement in survivability from colon cancer, so that is now a preventable cancer. This isn't necessarily a preventable cancer, but as you were just saying, Dr. Young, early detection is key. And this system that has been implemented is a relatively new process and involves a certification and proving that you're good at it. And we're good at it. So tell us a little bit about what that is.
Yeah, so we've actually been doing lung cancer screening actively in 2015. That's when we began. The program has grown substantially, about 360%. So
Wow.
we have a lot more participants than we once did. And a lot of that is key from primary care. Getting involved and asking their patients questions and finding out whether or not they qualify for screening. And then our program actually follows up on those patients. So not only if they have a negative test do we send them reminders for the year coming, but if they have a result, like you said, where we want them to come back, we contact both the provider and the patient to remind them that, this is something they may want to do and to contact their provider. But the program itself, you are correct. We are accredited through ACR, which is the American College of Radiology, and we had to go through some rigorous testing to get that accreditation through our CAT scanning department here at the hospital. We also have it's GO2. It used to be called Health Alliance, which was a accreditation known for centers of excellence for lung cancer screening. So we have that as well, and we had to do some paperwork and attestation to prove that we had that. So I like it that we're talking about this because, like this morning, I was actually having another conversation about this, and this being Lung Cancer Awareness Month, there's so many negative connotations attached to lung cancer, unfortunately. And I know when I talk to patients, because I do call each one of them individually before they come, just to verify criteria, and people are embarrassed, sometimes reluctant to come, afraid, and that is not what we're about here at Good Sam. We want to help people have the best life that they can have, and that includes detecting cancer early. So having that this platform to talk about this is really, really important because we want people to know that we are here to help them. And again, my phone number, I want to throw that out there, 812-885-3638 if you want more information or if you just want to talk to somebody.
Yes. And also just through the main hospital operator and then get put through to you guys is also a good way to
Sure.
get plugged in. You mentioned through primary care. Obviously, as you're seeing your primary care provider, we ask about those things. But sometimes patients need to bring it up and say, hey, I have a history of smoking in the past. And that helps to start that conversation. But a lot of it is just awareness. You had mentioned that there have been a lot of changes. This program started and now has become what we consider to be standard of care, something that we want to do on a routine basis. But what exactly has changed technologically as far as the equipment's concerned, and then the studies that have allowed this to really come to fruition?
So before CAT scan got to where it is now, we used to try and do lung cancer screening with chest x-rays and with even sputum samples, so coughing up and testing those cells for cancer, but they just weren't good enough. It was given a good try, but on x-rays, even though CAT scans and regular chest x-rays use the same type of radiation, the way we look at the chest is different. And so it's not possible to see those small nodules in the early stage on a chest x-ray. And that's what we're looking for. We want to find cancer just when it's starting so we can cure it at that time. And so when CAT scans were invented, they started out as pretty high radiation type of tests. And they weren't really practical. They were slow. But as time has gone on, our CAT scans have become very modernized. They're very low radiation. They're very fast. And they just are a lot smarter at putting together the information so that we can make accurate, detailed interpretation. And one thing I did want to talk about was radiation. So people are always afraid of radiation. They don't want to be irradiated. They know x-rays are dangerous. And to some extent that is true. But when we think about radiation exposure nowadays with these low doses, so when you go outside and you're in the sunlight, you're receiving a certain amount of background radiation, we call it. And so every day we receive a little bit of radiation, and our bodies are good at handling that. If we think about these imaging studies in regards to the amount of radiation we get from sunlight, a chest x-ray, which is the smallest amount, is about 10 days of walking around in the sun. No big deal. When we get to our low-dose CT scan, it's just about 2 months, which really is not much. If you think about the amount of radiation just from living for 2 months, it's not very much at all. That we live on this earth, and that does not endanger us in any way. Full-dose CAT scan is about 6 months of that background radiation, and as you get into the bigger, heavier studies, it goes up from there. So overall, it is not a significant amount of radiation.
And that's part of what has made this functionally working when these studies were performed, was looking at what that radiation dosage was, what the protocols were within the equipment, the resolution of the equipments, and then the system that is set up to do this continuous follow-up. And I think that's something that the patients need to understand, is this is a program that they get plugged into. This is not necessarily me saying, hey, it's time for your colonoscopy. We're going to do that every 10 years, and I'll order it and do a colonoscopy on that patient. This is something where we identify patients who have risk factors, or patients identify those risk factors, get plugged into your system, and then this is something that is an ongoing process.
It sure is. And one thing I really wanted to note, especially here with us talking together about the program, when we began, we were just like everybody else in the United States. 75% of our analytic lung cancer cases were stages 3 and 4, already advanced, just like everybody else. We are now exceeding 50% that are 1s and 2s. Mm-hmm. A huge difference. So not only do I wear the lung screening hat, but I also work in radiation oncology. So I see some of those people that are curative coming in for Sbrt. And I really want to emphasize that lung cancer is very curable if found early. People ask me that all the time because they're, like I said, there's this negative connotation that if you have lung cancer, that it's a death sentence. And that is not the case if it's found early. It just isn't. And I don't think that information is widely available or accepted by the public. And it's a great opportunity to talk about that here today.
Yeah, and I think it's important to realize statistically when we look at the numbers, there are some cancers we can't do anything about. We have poor detection for ovarian cancer, pancreas cancer, renal cancers, things like that. But when we look at the statistics on what we as humans get most commonly, which is breast cancer, prostate cancer, lung cancer, and colon cancer, those are the top 3 for us. And we've had good technology and good advancement in early detection and prevention with colonoscopy, with mammography, and improvement in resolution in those studies. And as we progress, this is the next natural and exciting step, in that we are now on the most common lethal cancer, and the studies are showing that the rates are going down. Detection rates are getting much better. The stage at which people are detected is getting lower, and as a result, survivability is getting better. So that's really the exciting part about it, and really the number of eligible people that are being plugged into this program is still relatively small compared with what we would like it to be.
Can I comment on
Yeah,
that?
please.
So I'm glad that you brought that up, because the U.S. Preventative Task Force has recently suggested to CMS to change the criteria. So we go by CMS criteria, which is 55 to 77, a 30-pack year of smoking, which means a pack a day for 30 years or 2 packs for 15 years, some equivalent of 30-pack. Well, with this recommendation, and we expect that CMS will accept this in February of next year. So that's going to change not only the age criteria, but also the pack year criteria. So age criteria, we expect to change from 55 to 75 to 50 to 80, and the pack year to change from 30 to 20. So that's going to encompass a lot more heavy smokers. And I mean, you all as physicians, you definitely see those people that are outside of that criteria that get disease. So I'm excited about that. I think that's a place that we can make a real impact.
Yeah, and the U.S. Preventive Services Task Force is really kind of what we use as the guide for most of our screening things, because it's very evidence-based. And that's one of the things that has changed a lot in the past 20 years in medicine, is we really want to have robust studies and data that back up what we are doing. And that's one of the big things that's happened in the last 10 years with the lung cancer screening, is that, as you were saying, Dr. Young, back when I was in medical school, people were still doing screening chest x-rays and executive physicals and screening EKGs, and what the study showed was that really wasn't helpful in any way. So having these very well thought out, studied programs that show good results and earlier detection and more survivability is really what this is all about. Smoking cessation is obviously a big part of what we do every day. Every patient that we see, we screen them for smoking. And it's important for people to understand that there's really not a too late time to quit smoking. And it's important to also realize that having a remote history of that is still important. You had mentioned the pack year requirement. That isn't that you just quit smoking today, last week, a year ago, so forth. If you have that remote pack history, it's still important to make sure that your provider is aware of that, because that's part of this criteria also.
It definitely is, and even being a non-smoker, again, you're still at high risk if you fit that criteria and have quit in the last 15 years. That's kind of a long time. So not to say that you're not doing the very best thing you can for your health by quitting smoking. Absolutely, that's the most important thing that a person can control for themselves. But it's still important to go over that with your provider so that they know.
Absolutely. So technology-wise, things continue to evolve. I had mentioned earlier that you're an interventional radiologist. Interventional radiology is a relatively young discipline, and I kind of think of it in terms of you're part radiologist and part proceduralist and part magician, and kind of a little heavier on the magician part, I think, really, when we see what you're capable of. But that's something that flows into early diagnosis as well with this. Can you tell people a little bit about what things you do in that category?
Yeah, so there are two procedures that I do involving lung cancer. One is something that helps with the diagnosis, and the other is for the treatment. So, for example, if we see a chest CT, a low-dose CT, and we see a suspicious nodule, well, we need to figure out what is that nodule made of. Is it cancer or not cancer? So using image guidance, I can go in with a special type of needle exactly where that lung nodule is, no matter where it is in your chest, and take a little sample. And when we get that sample, we send it to the laboratory, and then we get the diagnosis. So that's one thing I do, is just taking a sample, sending it to the lab, and figuring out what type of lung cancer is this, or is this lung cancer at all. Then, for those people that we detect early, radiation, as you described, is one thing that we do, but I also offer another procedure called cryoablation. So basically, similar to my biopsy, I have a special type of needle that I put into the nodule, and the tip of that needle freezes and destroys the cancer. So you don't need surgery, there's no post-op. The incision that I make is just a couple millimeters big, and that's it. And it can cure cancer. So that is a relatively new technique as far as lung cancer is concerned, and it so far seems to be pretty promising, especially for people that can't undergo surgery or can't get radiation for whatever reason. We do have other options that are available to them.
Really exciting stuff.
Yeah, and it's, that's the thing, is it's not just the technology of detection, but the technology of treatment, the medications, and those protocols, whereas the past days of being horribly sick with therapies like radiation therapy and chemotherapy, all of that has gotten better. Would you talk a little bit about your side of things on that from a radiation standpoint?
Yeah, so when I mentioned Sbrt, that's stereotactic body radiation therapy is all that stands for. So again, radiation, just like radiology, has so grown in the past 10 to 20 years, exponentially, actually. So the treatment for Sbrt for early stage lung cancer, for those, like you say, that have COPD and maybe can't have surgery, the treatment is 5 days. It's very, very specialized. A lot of planning work that's done on a computer with some special x-rays. All of that is planned out ahead of time. Patient is put in a particular position. There's no real prep for this. The patients can take their medicines, eat, drink liquids. They can do their normal things. And the treatment itself is about 30 minutes from setup to the time they walk out the door for 5 days. Much, much different than the way it used to be when they would come for 42 treatments. And like you said, a lot of the side effects are abated by that specialized, highly intensified radiation beam that is coned to a specific area, just the tumor, where we can skip treating anything surrounding the tumor, like the heart or the spinal cord. All of that's protected now, much, much better than side effects in the past.
Yeah, when we look at the old days of I want to kill the weeds in my yard, and I would kill the entire yard in the process versus going out and targeting those specific areas, my patients report who get the treatment that they feel fine. They feel fine during the day of treatment, the days following the treatment, because we're not killing as many healthy tissues. We are killing just the targeted tissues. And just like you were saying, Dr. Young, the amazing ability now of biopsy without having so much risk and recovery. Treatment without having so much risk and recovery has changed dramatically over the course of the past several years. And this is in many areas that you treat, not just lung cancer.
Yes.
So what can people expect whenever they get plugged into this system as far as what this is like? Of course, when I order abdominal CT scans and drinking of contrast and those types of things, what do they expect with this type of program? What will happen?
Yeah, so when we get a referral, the first thing I do is I check to make sure they meet criteria. I also help the doctor's offices by making sure that their coding is correct. This not only helps the physician, but it really
We're
helps
not perfect at that?
Really, yeah, they're not perfect at that. So, but it not only helps you all, but it really helps the patient, because there is nothing like being afraid or being anxious about a test, and then you get this giant bill in the mail. Okay,
Sure.
Lung screening is covered by Medicare, almost all insurances at 100%. Okay, but it has to be coded correctly. So we check those. And if they're not, then we help the physician's office get that coded correctly. And I know that's boring, but it's important to the patient.
Sure.
So they care about that. And then I call the patient individually and we go over their background. There's a intake sheet that we send to the radiologist, and it gives them some background information on this patient, not only their smoking history, but also if they have any family history, if they have been exposed to chemicals of some kind, if they have had any kind of occupational exposure in any way. So all of that is gathered in this intake sheet. So the radiologist has extra information. Whenever they're reading that, extra information is always good. So once the patient then comes for their exam, of course, they generally know when their appointment is by now because it's been done at the doctor's office. And I'll remind them where to come, that there's no prep for this test either, that they can do the things they normally do. What will happen after their tests are read? Will they get their results in my chart? Will they get a call? Will they find out? So we'll go over all of that. And I also remind everybody, as part of this program, all participants get a letter in the mail, similar to like a mammography test, that has recommendations based on their test. So I tell everybody that so that they're not alarmed that they get this letter in the mail. What does this mean? They're going to get that. And the information about having yearly testing is in there. If they have a pulmonary nodule, like you said, that's very, very common. We have a little, I actually have it with me. We have a little brochure that we send people about pulmonary nodules. It's very, very small. It just gives an example of what they look like and why it's important to have follow-up.
Yeah, and as you mentioned, Dr. Young, there are several potential outcomes, but there are lots of things, especially as we live here in the Midwest, that people get in their lungs that are totally benign, that may show up as an abnormality that you guys read as, yes, we see this in the reading, but it's not something that's concerning. Can you tell people a little bit about some of those things?
Yeah, so I mean, one of the most common things I see are something called calcified granulomas, so histoplasma. So just living here in the area we live, the dirt has little spores of things that we breathe in, and it just ends up making little nodules in our lungs. It doesn't mean anything. It's not a real infection. It's just a way our body reacts to the things around us, because we're breathing things in all the time by accident, and our body does its best to clear out our lungs. Some things stay behind and leave a little mark. And so when we see those calcified nodules, they're very obvious to us to be histoplasma or other type of granulomas. So those things don't get us too concerned. And so we know based on the look that they belong in the category of benign, meaning not cancer. And so we can just almost discard those nodules and pretend they don't exist. They don't go into the same type of criteria that would cause us to do more imaging and more examinations. There are other things too. Some things are nodules but are not cancer. For example, infection. Some people that just happen to have their screening study have an infection. They might not even know. It's just very small pneumonia. So sometimes we can tell that it looks a certain way. It looks like pneumonia, but we never want to accidentally say that it's not cancer. So we will usually do a follow-up imaging on them and just make sure that it's gone away, because pneumonia will go away. You will get better from it. Whereas cancer will stay. It will not go away on its own.
I'm really glad that you brought that up, because I actually get that from patients a lot. I think they think that if they just say, well, I don't have anything going on, I mean, there's nothing, that they can get their test and all is well. That's why it's so important to be asymptomatic, is because of that.
Yeah.
If there is an infection, it could cause them to have more testing that
Yes.
they really do not need. And it's not that we're not going to do you. We're going to do you. We're going to take care of you. But we want you to be, as asymptomatic as you can be. Finish that antibiotic, come back in 6 weeks, have your test.
Yes.
It's important, too, to realize that this is one of the many cancers that are essentially asymptomatic in the early stages, even in advanced stages. And so a lot of patients that we deal with will say, well, I feel fine. Why do I need a mammogram? I feel fine. Why do I need a colonoscopy? I'm not having any symptoms. Why do I need lung cancer screening? And it's because of early detection, why that is so important. Because, as you had mentioned, Dr. Young, most of the cancers that we deal with in early stages, stage 1 and stage 2, are very treatable, highly survivable. But lung cancer is one of the ones that the more advanced the stage gets, the survivability is significantly less. And so that early detection is so important. So that's why we encourage people, we should try to focus on the things that we can improve. The U.S. Preventive Services Task Force is excellent at figuring out where people should spend their time, their effort, and their money on prevention that's going to have the biggest impact. And this particular cancer, being in those top 3 and being number 1 as far as lethality, is why this is so important. So as we go through this month of awareness, the biggest thing is just that, making sure patients are aware that there are modalities now for cancer screening that are not only effective as far as detection, but change the outcomes, really help people survive and live better lives. The second thing is making sure that you get identified as what your risk factors are and getting plugged into the system, be that through you directly or through primary care or any of our medical services, to get in touch and make sure that that's taken care of. And then following through with it as far as your program is concerned, which is once you're in that system, you will continue to get followed up on throughout the course of that age range.
Correct.
Tiffany, any questions for us today?
Nope, no questions.
Very good. Any closing thoughts, Dr. Young?
No, but as a radiologist, I think lung cancer screening is really fantastic in helping our patients stay healthy and get treated early. And I hope that the viewers out there really take heed of this advice, because if you're a smoker between the ages of 55 to 75, lung cancer screening is made for you.
Yeah, and what I just want to say is, please don't be afraid. We, all of us here at Good Samaritan, are, like I say, in the business of making people better, making their lives better, better health, better wellness, better life. And this is just another part of it. If you have questions, again, please reach out to me, 3638, or your primary care. And I really want to thank primary care, because our program would not be as successful as it is without our primary care physicians that have been referring our patients.
Thanks.
Great, really great.
Well, we're excited because, again, this is a modality that years ago we didn't have, and it has proven so successful. And now that we're seeing those numbers shift, it makes us just excited, as when colonoscopy took off 20 years ago, that we've seen colonoscopy prevent colon cancer and keep it from happening. And we hope to continue to see increased survival, earlier detection with lung cancer screening in the future. Thank you all very much for joining us. We'll be with you again in the future. Be safe.